like the risk of the number of the appendix, if they have like a feculith, which is a piece of a stool obstructing the appendix, will lead to a recurrent attack. So usually we discuss with the family and we direct them, and the end usually the family want to take the appendix in an elective phase. They don't want to come again to have the same emergency situation.
Dr. Abdullah, I have a question here in Twitter. They say, what's the importance of appendix?
Still, like as there's no,
No.
we don't have any importance till now.
I guess just the surrounding lymphoid tissue.
There is lymphoid tissue. We use it, interestingly, we use it as for the bladder, like in a specific congenital anomaly. When the children have difficulty with their bladder, we bring it as a valve. That's what we use. We create it, but still, did we understand what's from like the God? No. I am sure there is a reason for it, but again, we don't know what's the benefit from the appendix.
Okay, so clear message for our viewers. Yes, appendicitis can happen in children.
Yep.
Yes, appendicitis can rupture, perforate. Sometimes can be life-threatening,
Sure.
serious.
Sometimes
They need surgery. Sometimes if the symptoms are more than 5 days, if it's perforated, then they need conservative, and then maybe surgery. The risk of doing imaging like CT scan, not ultrasound,
is higher
versus laparoscopic surgery is higher, right?
Yeah,
the risk
sure.
is higher. So we would like to advise parents not to push the physician into doing imaging just to confirm his diagnosis, because nowadays with the modern medicine, anesthesia, and a doctor like you and your colleagues, probably it will be much easier and less risk and less also stress for parents and child to do the laparoscopic surgery than going into the tons of radiation.
And not only that, he will need sedation for radiation.
Yeah, exactly. So
the child will be sedated.
Yeah,
so at the same time.
I agree with you. And to put 100 underlines for sedation, we are a bit not that much with conscious sedation.
Unfortunately.
We really actually need 2 physicians. We need equipment. I'm a director of a conscious sedation course, so I know we are behind in this area. So probably it will be much safer to do general anesthesia than doing conscious sedation, at least for the time
Hopefully
being.
with the help of the people like educated and coming, they're bringing their expertise, and the same. I think now we're seeing a lot of changes happening. So hopefully, inshallah, it will be helping for the sake of the patient.
Okay. Now let's jump into the second topics, which is we decided one of the commonest presentation or one of the commonest surgical disease in children is hernias. And I'm really interested in hernias because I see a lot of hernias, especially in neonate.
That's right.
And I see also a lots of hernias, not in probably first year of life. And the biggest question is surgery. When do we operate? Why do you keep telling us just wait until it gets incarcerated, which means twisting and getting stuck?
Yeah.
Why should I wait? And in Canada, they wait for months and months. Probably here in Kuwait, thanks God, there is a private and there is the speed and the government. But tell us more about hernia. How do they present? What are the anatomy of hernia? And also the pathology behind it, and also the treatment. Specifically, tell me, how can we make people like happy by telling them wait another month or 2 months, and they know there is something wrong going inside.
It's difficult. Again, it's mentally it's difficult when there is something going on, and specifically for the family, they have to understand the father, mother, their child is like precious for them, and they cannot. I appreciate that, but again, that's our job to keep talking, and give the confidence between us and them. Hernia, it's as I said, it's the most common elective procedure we do in children.
Allow me, can we just show the slides, please? Just let's have the double picture for the doctor on the slides. Yes, thank you.
So just before we speak slide, it's the most common. It's around 3 to 5% from all birth, more in the male than female. Like it's 5 to 6 times more than in male than female. And it's more common in the premature, like 30% will be in premature. And we can see in the picture, just to telling what's the hernia. Again, that's the normal, that's the peritoneal cavity, which is the end in the abdomen. There is a line of tissue which we know there is a fluid in our abdominal cavity with our solid organ. And usually at when the baby delivered, embryology, it will close, so it will be obliterated, and there is the testis, and that's what we call obliterated process vaginalis, which is the canal between the peritoneal cavity and the testis. If this canal doesn't close in this way, you can see the fluid will be going down to the end with a valve, which that's we can complete inguinal hernia. If it's just till the middle, and you can see the arrow here, it will be just in the upper and the groin. Let's see if it's closed and there is a fluid in the testis. That's what we call hydrocele, which is just a fluid. It's a fluid around the testis, and usually this type of hydrocele, it will resolve by itself. We like 80% will resolve by the age of 1 year. And there is other types when you have the same picture here, but only fluid coming out and inside, and we observe. And if it doesn't go by 12 to 18 months, then we'll suggest to operate. And this picture, that's how it look like. Like the child will
this
come.
This is a hernia.
That's
or hydrocele.
That's
hernia.
Again, by picture we cannot differentiate. You're right, but by examination we can see. But you can have see there is a swelling. There is a big swelling in the right side, which is more common than the left side, in the scrotum of the child. And the other way, they will come for us to the clinic, and the family will notice there is a bulge in their groin, as you can see by the arrows there and there, and it will come and go. The common question they will ask the family, is it painful? The hernia itself, it's not painful. They have a pressure, but it's not painful. It becomes painful when it becomes stuck, which is the other word, incarcerated. You just mentioned Dr. Abdullah. So when it's become incarcerated, then it becomes painful. And then if it's become red, and the child have like abdomen, his abdomen become big, and he cannot take milk, then we call this, there's risk of strangulated, which affect the blood supply to the bowel. So what we do for them when they come, and for regarding to your question, Dr. Abdullah, first of all, this needs surgery. It will not go by itself. Okay. Again, I will say it again. Inguinal hernia will not go by itself. It needs surgery to fix. Is it safe? It is safe. It's the daily procedure we do it as a pediatric surgeon. We are trained for this type. It's totally different than adult. It's different skills, different how what we are looking, and all the time there is like there is no weakness. It's like I said, there is a defect in the embryology. When to operate? To your question, usually we give them like our appointment, which is now in Benzina Hospital. Our appointment within 1 to 2 months. Our appointment now
maximum.
That's maximum 2 months.
Waiting time.
Waiting time, which is accepted for the term babies,
okay,
which have no incarcerated. Again, term baby, not premature, have no incarceration. That means the risk of incarceration is low. We do it urgently in 2 situations. In premature kid who born before like 38 weeker, low birth weight, there's risk of incarceration is very high. So that's the reason we try to schedule them earlier, within 2 weeks. We'll push them between the list, and we do them. And the other category, the incarcerated. When the kid have incarceration, which need to be reduced 95%, we manage to reduce them when become stuck by one of our team in Benzina Hospital. And if we reduce it ourselves, we admit the child and we do the surgery next day. Okay. That's our protocol, male and female. The risk in female also have to mention, we have couple cases here in Kuwait, which the ovary in female, the ovary could going out and could be twisted. So the ovary when twisted, there's risk of gangrene in the ovary. For this reason also, when we have an ovary and we reduce it, we'll do the surgery next day. The reason why do it next day, not in the same day, because there will be edema, there will be swelling. So that will make the surgery difficult, and we don't want to injure an important structure, which is the blood supply and the vas, which have the semens from the testis, to protect them, because they will be so tiny and they're so small. So that's the answering your question, when to do it and why we wait. And that's for the reason, and we tell the family. The only problem what we have, and it's good we ask this question to mention, and also unfortunately happen daily because the weather change, when the child cancel. Like let's say we have a 6-month age coming for his surgery. We give him his appointment. After 2 months, he's 8 months. Then he come to the clinic for his surgery. We come in the preparation, and he come and he have sore throat, or he have an upper respiratory tract infection. So what we do at this time, we cancel surgery as a protocol, because again, back to our basic risk versus benefit. His risk from the anesthesia higher from his benefit from his inguinal hernia repair. So unfortunately, this time we have this difficulty because the family, they have difficulty, you know, and we appreciate and understand that, because they take the time off and they're preparing their time mentally. They are prepared for surgery, and then it's cancelled. And that's happened not only on Kuwait, also when we were in our training. Hopefully, our teams, our department, we are thinking about them, and we try to squeeze them between cases.
Okay. So bottom line, for hernias, it's not an urgent surgical case.
It's an elective.
Elective, so people can wait. Parents, we should advise parents that this is not a serious surgery or like defect, unless it is
incarcerated,
it got stuck,
or it's a premature kid.
Yeah, or premature, and then probably they need
urgent. Semi-urgent. We do it like within 2 weeks' time,
okay,
and then we schedule them.
Now, I have a question here. They told me to translate into English. What about umbilical hernia?
That's a good question.
Yeah, we see a lot of umbilical hernia, and I keep telling parents in my practice, it will go by itself. It's harmless. Now a question is coming saying, how come you keep telling us it will never get twisted or incarcerated? Because it will never get twisted or incarcerated.
Yeah, right.
Can you just enlighten our viewers about umbilical hernia or belly button
hernia? Yeah. Again, that's another type of abdominal wall defect, and we see it a lot. We get referral a lot, as you said, and we see them. And what our rule, we reassure the family that it's like, I would say 80% of the time will close by itself, more in male than female. It will close.
Everything is more male,
and it will close. And some rare, we close it if they are so big defect. I remember a girl I defect, I closed her like she was 2 years, but her defect was like this, which is like, you know, as a 2 years old, is very big. And we know it will be like, you know, it will difficult to get smaller when all the time to get out. The usual size, they are usually like this, like a couple, like less than a centimeter or half centimeter, and majority of them will close. And the family themselves will notice, because they will put their finger and they will see there is no defect anymore. And again, as a general rule, we tell them to keep an eye, because it's very low risk, but it could happen. As we know, we say in medicine, there is no white and black. It's very rare to get incarcerated. And I have to say never, but maybe tomorrow we'll see. I never say there's incarcerated hernia in the umbilicus. But again, as I said, when you say never, it will happen to you in your practice. But we tell that's for the family to watch for redness, specifically. Redness and tenderness, then all the time come to the emergency.
Question from Twitter is regarding the same things. What about, I'm trying to translate the Arabic into English.
Sure.
What about using the coins? The coin, yeah, I guess this is a question. We see it a lot. They try to put 100 fils or any coins, and then they wrap it.
I usually say it's 50 is better than 100. I'm joking. I'm telling the family.
My advice to the parents, I usually say it's up to you, but there is no evidence that the hand, actually it might damage the bowel.
It might damage. The skin irritates from the material of the coin. You know, we have it when we were back also, they say the penny. They tried to tell the penny is a small. And the same thing, there's cases, it's reported, they have an allergy from the material, from the cover, and this affect, they have rashes.
But do you know that they sell a belt now with a metal inside, covered? Or
it could be, but there is no evidence for that help. We told them that sometimes you could cover it, you could make it protect the skin, but we don't have an evidence. It's up to you, like, you know, doing an extra or something, like, you know, mentally you think you're helping, but sometimes it will not help. We are afraid from make it force by the skin irritation. And that's, as we said, is like a symbol, it's closed by itself. It's not something you will be scared to face. And also, if he need a surgery, the age we do the surgery at 4 years. So like before going to school. They will be also older. We do surgery for kids within, like, you know, premature kids. Like they are like 1 kilogram, we do surgery for them. And we have the qualified anesthetists, good nurses. So what about 4 years? So it should be much easier for 4 years.
Yes.
And that's, again, it's reassurance. I think people need to be reassured and reassured, and give them the time.
I guess most of our parents and most of our families, they just need to be educated toward these
Totally.
kind of diseases, and they don't bother their physicians, because one of the things that's probably annoying when they come to you and they say, oh, look, this umbilical hernia, when you press it gives noises, like a
which is
bubble,
the sound
bubble,
of the bowel.
Yeah,
it's the sound of the gas.
And it is scary for them. I have no idea why. But anyway, saying that, let's just clarify that umbilical hernia, brackets, it's non-harmful kind of hernia.
Again, it's elective.
It doesn't need surgery unless it's years.
We just watch and see till become the age of 4. It's usually gets smaller. The family, they come and tell us it's becoming smaller, unless there is have any problem with incarceration, which is very rare. Not rare, very rare to have symptoms. And they said majority of the time it will close by itself.
Dr. Abdullah, we have only 10 minutes. Time is flying. It's been really interesting, and I'm really paying attention more than anybody, because it touches my.
I know. Again, it's interesting because you're speaking the same language.
Yeah, it's touching my specialty. Now, let's talk about undescended testes.
Sure.
I guess we chit chat a little bit on the phone about undescended testes. We have lots of cases of undescended, whether bilateral, whether both of them.
Most common is unilateral. We have bilateral. We have associated with another congenital anomaly, but we see all of them, and some of the cases which usually, combined with endocrine, which is the rare. I'm not, but I will just speak about the general.
Which is, you mean Klinefelter and
kind of with the other syndromes, which we have seen between us and the pediatric endocrinologist checking for the hormone is the rare. That's the least. I will not, but just to speak about it, not confuse.
Let's talk about common.
There's common thing again. Undescended testis. It will be. See, that's the picture. So it's there's a couple type of the testis. As we said, normally testis will be descend, while the child embryologically in his mother abdomen, the uterus, and it will descend down, and that's what we call descent testis. It will be following the normal path. When the child delivered, there is some of them, the testis will be not in the scrotum. So then we get the referral. Again, we can see the picture, what we call the true undescended testis. The testis could be inside the abdomen, which means you cannot feel it. Could be in the inguinal region, which is in the groin, you can feel it up, or in the higher in the scrotum, but it's not in its position, which is the mid scrotum, sitting nicely. The other type, which we call ectopic, which that means didn't follow the pathway of the embryology, which means it will be coming and not in the pathway of its normal position. Here we can see that's how we diagnose by examination. People think of imaging, ultrasound, MRI. Again, the recent recommendation that the most sensitive is our hand. What we do the milking technique. As we can see the picture, we pulling in the scrotum and we try to milk from the groin down till we try to push the testis to bring it down if it's up in the inguinal canal. That's brought to be another category. It's what we call the retractile testis,
which goes down,
which is it's like going like bingo. Going down and up. And we tell the family there is a criteria to call it retractile, which sometimes the chubby kid, they have overweight. You can see there's which is related to the cremasteric reflex. They the reflex which make the testis by the muscle build up. The testis will be going will be up, and will in the clinic the child will come. The family complain that we don't see the testis in the scrotum. So when you're laying down the child, you feel the testis good size, you bring it down to the scrotum, and there's 2 criteria we ask to keep to make sure that it's retractile. We manage to bring the testis down to the scrotum. The second one will be the testis will be staying after I release my hand. So I'll bring the testis down the scrotum. If I release it, if the testis is going up like the bingo one, then that means it's not retractile. That's undescended, needs surgery. But if it's retractile, we don't do surgery. We just follow up, and usually it will relieve by itself when he will become 10 or 12 years of age. So we keep follow them 6 monthly, yearly for the retractile. For the undescended, when we feel it and we cannot bring it down, or like, let's say it's smaller in size, then we tell the family, we wait till age of 6 months of age, because some of them will come down till the age of 6. Like, we just follow it clinically each 3 months in the clinic. If they didn't come down, then we tell the family at age of 6 months, we will book them to have a surgery between 6 and 12 months. Why we do the surgery? That's the question. Like a lot of people, when we tell them, and we tell them that why we do the surgery is not only because the fertility. The evidence say there is some sub-fertility issue, but they are fertile. There is higher risk of cancer. That's so important to tell. We tell our patient, that's the child, to bring the testes down. They have like, around 10 times more than normal population to have risk of testicular cancer, which is already rare cancer. So it's easy to feel. If it's in the abdomen, it will be double. It will be much higher. So they cannot feel it. They will come with abdominal mass when they are like in the 30s. The other risk, testicular torsion, when it's in the groin or higher, you don't feel it, and when you get hit, you will be hit here and you'll have torsion. And we have cases. That's real life. We have cases. They come, they have endocentistis, they have torsion while it's in the groin. So it's much higher and difficult to diagnose. As it's in the scrotum, you can feel it. You can do the Doppler's. You can elicit. The fourth one is the risk of hernia. Usually there's hernia. Like 90%, there will be like a patent process with the endocentistis, and then you have to treat the hernia, because there is a risk of recurrence if we don't treat the hernia. Unfortunately, there's some 20% of the cases we don't feel the testis. Like, we try to examine the groin. If the patient come, we feel the groin, you feel the testis is high. At age of 6 months, we'll give an appointment after 2 or 3 months. Then we'll do it. He'll become like more big in size. We do it, and we do it through the groin, bring it down to the scrotum. We fix in the scrotum, we keep it down. Let's say we didn't feel it. We don't feel the testis. We feel one and don't feel the other one. Then which will be the other option? We put the camera. With the camera inside and looking inside the abdomen to see the testis, where it is. It is easy to bring, because as we know, like as a surgeon, the one will hold the testis from coming down is, we have two things, the vas and the vessel, which is the blood supply. It's usually the blood supply. Not the vas. The vas all the time have no problem with it. So the blood supply. So we see if it under tense, what we do, we call a procedure is Fowler-Stephen, which we make a clip the artery, and we bring the child after 6 months. We do another laparoscope and we bring it down through the laparoscope.
So you cut the blood supply?
We cut the blood supply, the main blood supply.
Then it will die?
No, it will, that's again, that's what we
collateral
found. Collateral. Okay. Again, that's what will happen. They find collateral will come from the peritoneal, from the gubernaculum. So wow. the kid will develop collateral, and there is, that's they found is much better survival of the testis. As we know, the downside of this procedure is low risk of testicular atrophy, which will be like, when you bring it under tension, the blood supply could be dying and the testis could die. And all the time we notify our patient, we tell them there is a risk of testicular atrophy. That's why we follow it up to 6 months of age after surgery.
Abdullah, if we are talking about retractile, what's the cut age?
Good question. To
do surgery if it doesn't come down.
Again, the evidence say, that's why I'm saying, the evidence say there is no cut age to wait. The only thing, if it's become smaller in size.
How do you know if it's up?
We examine. The patient come, we see
them. We use the beads, this one.
So what we would come, we bring the patient to the clinic each 6 months in the beginning, first 2 years, and then we do it yearly, unless the family notices some different. We bring the testes down. We compare 2 testes to each other. If one is smaller than the other, we do surgery.
But usually the right side is smaller than, actually the left side is smaller than the right side.
Again, but it's like if that's frankly smaller, what I mean. And the other thing, as I said, if the testis, we bring it down easy and staying, when I release my hand, if it's staying in the scrotum, we don't do anything. Usually when at age of 10 and 12, when they have the puberty, then
it will come down by itself. And if it doesn't, you do the surgery.
And if it doesn't, then we, for the sake of the family, we discuss with them doing a surgery. And again, I remember I did it once in my training because the family, they are annoyed. And they cannot, like, they say we cannot sleep at night. We came a couple times to the clinic. We think our child will be affected.
But what about the risk of cancer?
Risk of cancer?
If it's retractile, there is no risk
of cancer. It's only for undescended testis. The one who is not descending.
Even if it stays in the
groin?
In the groin?
It will come down by itself.
But I mean, intermittently, by itself.
That's why it's called retractile. It's coming down and up.
Oh, I thought it's called retractile because we can't push it down.
No, because the muscle reflex, in the thigh, the inner thigh, it will bring it up and bring it down. And the other thing,
the
cremasteric reflex. And the other point, going to clarify, risk of cancer will not go after surgery. People think by bringing the testis down, there is no risk of cancer. No, there is still the risk is there, but it's easy to see, easy to identify. There is like a mass in the scrotum. That's the whole benefit from this thing, to keep it down and have the fertility for the temperature issue, as we know.
Dr. Abdullah, we have lots of topics to talk about: testicular cancer, solid tumors, bowel obstruction. I guess we need to cover those in the next show. Hopefully we can have you again next Sunday to do the part 2 of pediatric surgery. We do have lots of another reportage, but we're gonna hold it until next week, inshallah. So at the end of this show, I would like to thank you very, very much for being patient and for being so informative. And I'm really glad to have you in this show. And hopefully we can see you again next Sunday to talk more about tumors and bowel obstructions.
Okay.
Thank you very much.
Thanks, and inshallah we'll be having you. Thanks for this opportunity.
So back to our viewers. Before I say good night, I would like to remind you of our fax, telephone numbers, emails, and Twitter. You can call us, fax us, tweet us, or email us any question you have regarding pediatric surgery, or even regarding future topics that you would like us to talk about it in the next couple of weeks. Before I say good night, Dr. Abdullah, once again, thank you very much.
Thanks, Dr. Abdullah, for
and good night, everybody, and have a great night. Thank you.